First name's Donnie, last name's Glover. In it to win it for the long haul, baby. This is the New Life Recovery Show. Our theme is if I think better, I can do better. Our very special guest today is former delegate and physician extraordinaire, Dr. Dan Morhaim, MD. Welcome to the show, Doc.
Donnie, always good to see you, be with you, and thanks for all the good things you were doing.
Man, you looking great.
I'm excited. Got a big election coming up. Got some work to do. Lots of other things going on. So, yeah.
Are you a Republican?
And no, I'm a Democrat.
Oh, way to
I
go.
am a Democrat. That doesn't mean when I was in the legislature, 24 years, I was a lead sponsor of 139 bills, all with bipartisan support. That's pretty good.
That's damn good. So I figured we would start off and let you plug your book.
Oh, thank you. Just so happens I have a copy right here. So this is Preparing for a Better End by Dan Morhaim with Shelley Morhaim, my brilliant and wonderful wife, who is the co-writer, editor. And it is about don't all run for the hills, death and dying. Yeah. We're going to talk a little bit here about end of life care, something
Hey.
that we're all going to face one way or
Nobody
another.
gets out alive.
Despite all the great advances in healthcare, the death rate is still the same, one per person. That's how it works. We each get one, and you don't know what's going to happen. You get to be a senior like me, not a young man like you. Senior like me, you think about it more, but this can happen to anybody, anytime. And so this is about empowerment, respect for values, managing yourself more within the healthcare system, taking care of yourself so you take care of your family, and all of this is available for no cost. Complete some free paperwork and take advantage of hospice and palliative care early. But we don't do it because we don't like to talk about this topic. And I get it. I don't like talking about it. I don't like thinking about it either. But we're in a reality where this is all available to you right now. And the best one, their advanced directive forms, is the punchline here. Complete your paperwork. Just like the little child on the toilet says, no job is complete till the paperwork is done. You have to complete the paperwork. And it's easy. And they're available from many sources. State Attorney General, faith-based, AARP. My personal favorite is mydirectives.com, free and online, mydirectives.com, mydirectives.com. Name and password, and it's also the one that's been authorized by the state to be the interchange for this information. So it's secure and safe. Walk through the whole process, and you don't have to fill it out all at once. You can fill out most of it now, or a month from now, your relationships change, your health changes, whatever, if something changes, you go back in, log on, and update it. Nothing could be
What is
easier.
the purpose?
The purpose is, and I'll switch now take off my legislative hat and put on my ER doctor hat. When you're brought into the hospital in the ER and we don't know who you are, if you can speak and relate, that's fine. Then we can talk to you. We know what you want. But if you can't, for whatever reason, accident, injury, coma, drug overdose, whatever, we have to call people and figure out who you are. And that's a challenge, and that delays care. It makes it more complicated. And if it's an end of life situation, I got interested in this in part because I found myself doing codes in the ER, ordering codes to be done, which you see on TV. It's not so neat as it's in TV, with all the chest pumping and tubes and things like that. And I'd have to ask myself, why exactly am I doing this? It looks like this person should be allowed to die in peace. Now, at times it's entirely appropriate to do full resuscitation efforts, but there were too many times where I can paint the picture, somebody 99 years old who is demented in diapers, contractures, they don't move their limbs, they have feeding tubes, and then we're doing a full code? Really? If that's what they wanted, if that's what they would have wanted and expressed it, I will respect that. It's not what I would choose in that situation, but I respect that. But when they have nothing, we default over to doing this stuff. We spend a lot of money, and really it was hurting people more than helping them. And so it was a very difficult situation that got me interested in the topic of what if I knew what patients wanted, I could respect that. And all they have to do is fill out free paperwork and have it be available.
So this came out of empathy.
Yes. And there was an academic study about it too, because I was very fortunate in the legislature when I was on the faculty, also at the School of Public Health at Johns Hopkins part-time, I had a wonderful set of legislative aides, all of whom have gone on to great things. Clarence Lamb, now state senator, chair of prevention medicine at Hopkins. David Fakunle. David is chair of the Maryland Lynching and Reconciliation Commission. This was my intern staff. And the last one, Keisha Pollack, now Keisha Pollack Porter, who's now chair of health policy and management at Hopkins School of Public Health. But then she was volunteering graduate student, young professor in my legislative office. And I said, Keisha, how many people have completed advanced directives? I can look up how many people have any number of specific diseases, kidney failure, heart attack, sickle cell disease, broken hips. That's all noble. How about this one, which is subject to everybody? And she came back a couple of weeks later and said, nobody's ever done that study. Really, the taboo of talking about death is so profound that even the public health world doesn't look at it. And then, so we got a grant and did the study. And what we found that only about 40% of Americans had completed advanced directives, and half that in the minority population. So in the American Journal of Public Health, we were the first to formally identify that as a minority health disparity, a term that's more commonly known now, but not so common then. But we also asked people, if you don't have an advanced directive, which is 60% of people, and this was all done with graphs and statistics, so it was an analytical study. It wasn't just sort of a bunch of numbers thrown around. I mean, we went through all the rigmarole to get a peer-reviewed published study. If you don't want one, would you like to have one? And 90% of the people said yes. So 90% of 60%, 9 times 6, 54, 54% of the public would want to have one, but they weren't getting them because people don't talk about it. We clinicians don't bring the subject up. People are afraid to bring this subject up. And I get it. It's hard. Look, I got elected 6 times. I never lost an election. And I was out in the community after sessions and saying, yeah, we do our end of session wrap up or talk about issues. And then I'd always say, by the way, I want to talk about, death, your death, the death of everybody you know, all your loved ones. And don't forget to vote for me in the next election. And people said, are you crazy bringing this up? I mean, politicians want to be at happy things. But people came up to me and said, thank you for talking about this, because I've had this experience with a family member or relative. Just like the first women to talk about breast cancer, or somebody to share about a child with a learning disability. These were taboo topics, and I want to break down that taboo because it's really ultimately about empowerment and respect for values. And in the minority community, especially more so, given how the healthcare world, the universe has not treated minorities as well as it should have.
Speaking of which, you've worked at Sinai.
Yeah, I'm still on staff there. I stopped doing shifts a few years ago. 45 years of ER shifts was enough, but I do medical things. I do volunteer physician work now.
And to say the least, you've treated a lot of Black people.
I've treated all kinds of people, and yes, a lot of Black people, but all kinds of. The ER is the front door for anybody and everybody. I also volunteered at a homeless clinic, worked on the Navajo Indian reservation, was in Saudi Arabia and Kuwait after Gulf War I. I was the medical director for the 1983 Major League Baseball All-Star Game when it was at Camden Yards. So I did a number of things like that.
I want to talk about Suicide Prevention Month.
This is it.
I didn't know that September was the month. I mean, I cover a lot of things, but suicide is a lot more prevalent than the average person realizes.
It is a, it's a tragedy. It's a hard thing, for the people around the person who committed suicide, because families are wondering and friends are wondering, gee, could I have done more? Why didn't I see the signs? Why didn't I step in and do something? There are a lot of suicide attempts. The most successful, not surprisingly, are when people use guns. So if you're seeing somebody who's going looking like that, see if you can get at least the most effective methodology out of the way, get rid of the guns. But it's it's a sad statistic, and I think it speaks ultimately to the dislocation and isolation and loneliness that too many of our fellow citizens are experiencing.
Has COVID escalated suicide?
Good question. I don't know. That's a fair question. I don't know the answer to that. I wouldn't want to speculate. Why do you
but
suggest that?
but COVID certainly has caused more isolation.
Yeah, I can tell you this much. The last I looked, which was a little while ago, the biggest subcategory of people who died of overdoses were middle-aged men. Might be surprising. I mean, you tend to think of, oh, this will be younger people overdosing, but it's actually middle-aged men in Maryland are one of the higher demographics of overdose death, whether accidental or intentional, you can't say. So the issue of drugs is an interesting one, and drug use, and the deeper question that we never want to confront is why do so many Americans turn to drugs? And a
What do you
lot of
think?
it, I think there's lots of reasons. Some of it is poor decision making. Some of it is uh, policies. We tend to think of this as an individual people, but actually there have been government policies and business policies, which I do a whole talk on over the decades, that particularly targeted, created the situation that we're in. And it goes back to President Nixon, goes back longer, but I'll use President Nixon when his former chief of staff, John Ehrlichman, after going to prison for Watergate, later revealed the origin of the war on drugs. And he said we had two enemies, hippies and blacks, and we could target them for associate hippies with marijuana and blacks with heroin and bust up their houses. And I mean, this is almost a literal quote, arrest them and destroy their communities. And did we know we were lying about the drugs? Yeah, we know we did. We knew we were lying about the drugs. And so that created this whole prison industrial complex, a lot of people getting arrest records and then being disenfranchised, not being able to vote. This is back now the 1970s. Some of that has been corrected, but not much. And so from their point of view, not mine, their point of view, that strategy worked. They actually did succeed in disenfranchising lots of black voters, prisoning lots of black people, and doing a whole set of other things that are the catastrophes that we still live with today. The other element was the pharmaceutical industry, or some elements of the pharmaceutical industry. I was in the legislature in 1999, actually from 1995 to 2019, but around the turn of the millennium, 1999 to 2001 and 2, suddenly all these pain bills started to come up. Pain is this, pain is that, pain is a fifth vital sign. People are suffering from untreated pain. And I knew it was nonsense because I worked in an emergency room and people came in with pain. We treated it. The nurses were compassionate. The physician's assistants, the physicians, we would take care of it. We'd employ the pharmacists. We'd figure out, what's the best. We wouldn't let people writhe in pain. There's a hearing, and I could actually show you the hearing. So suddenly all these pain bills start appearing because these very charming lobbyists started coming into Maryland and every other state, not just here, every other state, and saying you got to do something about this. So all these well-meaning legislators were kind of hoodwinked into introducing these pain bills. And I, in my talks, have a sign-up sheet for the hearing, and the first one is so and so American Pain Initiative, and the next one is so and so Maryland Pain Initiative. Charming, good-looking lobbyist types. Turns out later they were all funded by Purdue Pharmaceuticals. And then the Maryland Board of Physicians got involved, the entity that licenses me and enables me to work. In their newsletters, they would put out newsletters, and I can quote this. The problem, not doctors are not treating pain. Here's an 800 number you can call. The 800 number was a Purdue pharmaceutical drug rep who told you that OxyContin was safe. This is in their newsletter. And it also said, quote, the problem is, quote, physician reluctance to use morphine. What's the opposite of the reluctance to use morphine? Give more morphine, narcotics, prescribe more. So surgeons who would discharge patients with 5 oxycodone pills were now prescribing 20, 30, 40 because they were this huge thing. They even had in the Maryland Board of Physicians newsletter, a conference that they sponsored. And it says right there, we want you to go to these conferences sponsored by Purdue Pharmaceuticals. What do you think Purdue Pharmaceuticals was pitching? Narcotic use, overprescribing. We all kind of got herded in as staff doctors to go hear those. And I remember the one that I went to, and somebody asked the speaker, who's obviously paid by Purdue Pharmaceuticals, is OxyContin addicting? That was the question from is OxyContin addicting? And he said, no, the pain soaks up the OxyContin. That's the biggest load of crap ever. And so there was this, and nurses got called in on this, everybody, in this huge industry-wide plan. These were decisions, both the government ones and also by Bill Clinton and Ronald Reagan separately in their own ways, as well as industry. These were decisions made in boardrooms. People consciously making policy decisions to do this. It wasn't random happenstance. It was sitting around, let's do this thing. And from their point of view, they succeeded. The rest of us, however, it's been a terrible loss and a travesty that's been pushed upon us.
And when did this start? When did these pain bills start?
1998, around the country. I was involved with the National Conference of State Legislators. Every group has its organization. So I was meeting state legislators around the United States. And of course, this was happening everywhere. They had these lobbyist squads, fanned out to every state legislature, the federal Congress. This didn't happen by accident. These were conscious policy decisions. The other side of it, of course, is you should be able to think of policy decisions that reverse this. And the first bill I put in on addiction treatment issues to increase addiction treatment, substance use treatment, was in 1998, long before, and it was actually passed. And it did start to shift and wake people up to what was coming. Because it wasn't that I had some sort of, genius foresight. I was working in an emergency room 9 months a year, 3 months in the legislature, 9 months in the year. I could see what people are coming in with, substance use, mental health issues, obesity, tobacco, and so I would see that in the 9 months as a year, dental problems. I mean, a whole range of things. And then I would try to figure out, well, I'm going to be a legislator next January. How can I try to address some of those? That was kind of how I thought about those things.
Let me shift gears a bit.
Sure.
As we look at Southeast Asia, China, the Middle East, I've learned a thing or two, and I just want to bounce them off of you. It is my understanding that 90% of the heroin comes from Afghanistan, and about 90% of the fentanyl comes from China. Is that right?
I don't know if it's 90%, but yes, basically. And China's gotten cleverer. The fentanyl's harder to transport, so they send the illegal chemicals that make fentanyl over to labs in Mexico and other places. And then that's when the fentanyl is made. But of course, as El Chapo was asked, Joaquin Guzman, why do you sell drugs? He says, because you buy them. I mean, as long as we're buying, they're selling. And whether it's fentanyl this week or there's other drugs coming online, they're going to continue to sell stuff as long as we consume it. So we can get hung up on fentanyl. There's the drug called etomidate, which is now coming into it. There's, the animal tranquilizers and stuff. The deeper question is, why are so many Americans, with the stresses of life or whatever we have, choosing that path? Now, some of it is this long creation that I described briefly. But some of it is we have to really ask ourselves some hard questions. Why are so many of our fellow citizens turning to that? And my sense is from talking to a lot of them, it's just this feeling of isolation, not connecting. Look, I've stressed in my life, but I'm not using hardcore drugs. And because I have work that's meaningful, I have family, I'm very blessed, good wife, friends like you. So that otherwise, but I talked to a lot of the patients and they didn't know I was in politics or cared. And I'd say, tell me about your life. And they described their lives, dislocated family problems and childhood traumas and all kinds of things. And the dialogue in my head to myself was, heck, if that was my life, I might be using drugs too. I'm not that strong, but I get it. You're so alone, unemployed, and lack of education and all these things. And so a lot of the issues that we're in are related to that. And it is the international global drug trade. We are shipping vast sums of money overseas, like to Afghanistan, and other places, to funding terrorists that would come in and attack us from the outside. This policy is really bad. Just to give you a number, let me give you a number. There's about 30,000 hardcore daily substance users in the greater Baltimore area, not just the city, the greater Baltimore metro area, because it's not a boundary thing. I would ask my patients, so we were talking, I'm sewing a laceration. How much does it cost? $50 a day. Could be 25, could be 200, but let's say it's $50 a day. You can play with these numbers, make 30,000, 25,000, or 40,000 times $50 a day. But if you do 30,000 times 50 times 365, that's $550 million a year just in our metro area spent just on the drugs. Forget healthcare costs, innocent crime victims, insurance, all the other tragedies that occur related to drug use. Temptations for corruption by certain members of law enforcement, the prison industrial, all that stuff is there, and we're exporting 550 billion from our little community. Maryland may be $1 billion a year. We're a small state, so you think of it in colossal numbers. This is the biggest industrial complex on the planet, probably, and we persist in policies that feed this machine.
How does it fit into war? Let me give you a scenario. In 1997, I think it was my first year in grad school, and I'll be graduating in May with my master's in journalism, finally. But
you should be the professor, not the student, because you're already a brilliant journalist. But go on.
Bless your heart. I did research. It was to be my dissertation on the reversion of Hong Kong to China. And I learned that Great Britain owned Hong Kong for 150 years because of the Opium Wars. And so when I was seeking to prove that China would not destroy Hong Kong's economy and Hong Kong's economic relevance to the rest of the world. The West was saying that China was going to destroy Hong Kong. The Chinese had no idea about capitalism, and I began to learn about Confucian capitalism. But long story short, if you took my country, if you took my moneymaker, my New York City, my Hong Kong, for 150 years, and then I get it back, to me, that helps explain why China is relentlessly distributing this fentanyl. You did it to me, so now I'm gonna do it to you.
Your understanding of this is far greater than mine, but I get your point.
Afghanistan. The Russians went in there. All of these different countries went into Afghanistan to destroy it. It's supposedly a Muslim country, but they sell heroin. So are we over there for democracy, or are we over there for the heroin?
Well, we're not over there now, but who knows? I mean, those are really good questions. I've thought about those in different ways myself. What you really want to have, and it also feeds, in the United States, our border crisis because of the narco wars. Let's bring it a little closer to home, south of the border. I've had occasion to take care of immigrants, or legal and illegal, and to a large extent, they're behaving rationally. I mean, if you live in a town that's run for drug wars because we buy the drugs, it's irrational. What would it take to get you to say, hey, family, we're going to walk 1,000 miles from Guatemala or Honduras across Mexico to maybe get to the border of the United States through all the trials and terrors and things. Things really have to be bad. We're going to move to a different culture with a different language, and we're going to be looked on differently. It has to be really bad to get you to flee. People only flee their native places when it's really bad. And so they're behaving rationally from their point of view. And probably what I would do if I was in that situation.
Rationally or irrationally?
Rationally. If you're living in a terror zone
You
run
trying to
by
get
narco
out.
terrorists, time to get out. That's what I would do if I was there. But we prefer to say all these people are terrible, let's blame them. The real issue is because of our intense national consumption of drugs, we're feeding the narco wars that are driving these people out. We're contributing to the border crisis through our own actions. If we could take our huge sums spent on drugs, and I just gave you Maryland, think of add that up to the entire United States, how much money that is, and we're able to invest that in more rational agriculture, industry, and democracy and freedom in those countries that are south of the border, people wouldn't flee. We'd ease our border crisis because the underlying cause is the terror that the narco wars. And I've heard some descriptions from people. I have a friend who lives in Baltimore, but his family's from Sinaloa, his wife's family, and it's pretty safe to say. But when you start seeing the white Suburbans driving around, that's the signal to stay home. Don't go out on the street. When the trucks all start going in convoys, that's get out, get out, get out of the way. And so and this group lives actually better than most. So we have to own our responsibility in this. And if we
Is
could
the
deal with our drug issue ourselves more creatively with supervised consumption facilities, which has been introduced in the legislature for a number of years, if we could increase treatment on demand. I mean, as an ER doctor, if you came in with a broken leg, I could treat it. If I couldn't treat it, I'd get you an orthopedist, even 3 a.m. on a Wednesday night. If you came in with a heart attack or asthma attack, that I could treat it, but if I couldn't fix it or turn your asthma attack around, I get care for you. But you come in with an issue that's related to substance use, whether it's your primary reason, hey, I'm a drug user, I want to get off it, or it's a secondary reason, I have a bad abscess on my arm from dirty needles and it needs to be drained, of which I have done hundreds, if not thousands. Or I'm coughing because of the drug use. I can address your somatic problem. And then I say, well, for treatment, what about treatment? You want to go to treatment? Here's a bunch of phone numbers, go call. That's worthless. We need to have 24/7 treatment counselors in ERs or in person or virtually to get those people into programs right then and there, because there's often that moment in the emergency room, which all substance users end up in sooner or later for one reason or another. They almost all end up in ERs for a host of reasons. They don't have insurance, they're not getting regular care, all that. So when they get sick, that's where they show up. So I've had occasion to talk to literally thousands of people. They didn't know I was in politics or cared. So I just say, tell me how you got started. How much does it cost? What do you do? How do you get the money? Have you been in treatment? What's going on? Tell me about your life. They would just talk and I would just listen. But if we could have that, that would be a big step forward as well. Just yeah, I mean, it's 24/7, 365, have people there available to start talking. Let's say I came in, you were the doctor, you say, well, Dan, it's pretty obvious you're here now because you've been shooting up and would you like to talk to me? I said, okay, you give me a bunch of phone numbers, it isn't going to happen. We got somebody right down the hall here will talk to you, or we can connect you to. Okay, that's a start. Maybe I get better, maybe I don't, but you move people by degrees from lives that are really dangerous and excessive to something more normative and less harmful for them and for the community around them. Let me relate it to crime. There's a hearing, and I always try to have the source material. I think I've sent it to you before, Donnie, but it was a hearing in Annapolis where I asked Baltimore County State's Attorney, Scott Schellenberger, it's on tape, you can look it up, how much crime in Baltimore County is due to drugs. His answer, quote, upwards of 85%. Upwards of
wow.
85%. Next to him was Major Byron Conaway. Major Conaway, same question. Baltimore City, 90%. Quote, 90%. Gee, if 85 and 90% of crime is due to the drug issue, and all those people having to raise $50 to $100 a day for 365 days a year, why aren't we dealing with that head on? You know, it's, it's just be cheaper to give them the heroin for a few pennies rather than have them go, commit all this crime, petty and major. Let me give you one other number. I worked at a homeless clinic, volunteered for a few years. And a lot of the people were men who'd been in jail for obvious reasons. Not all, but many. And I would talk to them. I was never rushed there. The ER was always busy, but there I was not rushed. And I remember one guy very distinctly changed my perspective on a lot of things. I was slightly terrified, candidly, when I went in the room. He was a big, strong, muscular guy. But anyway, he turned out he was brilliant. And he started, he had a petty arrest when he was like 18 years old. So the doors to employment, education, housing, legitimacy closed. And he got into drugs. He worked his way up. He told me about the crimes, the murders he committed. Eventually became a big time drug dealer, got caught, spent 20 years in prison, 25 years in prison. So he went in, he was about 29. Now I'm seeing him at age 50 something. And he needed a physical exam to go to the, parole and halfway house, whatever it was. And that took a minute to see his physical exam part. So we talked for about 40 minutes. And he told me about the business and how he ran it and how the drugs got shipped in huge duffel bags. And they'd break it down and how the money got laundered up and the businesses that he owned with the money and stuff. And I said, so it's just you and me in the room. What were you making? What were you personally taking home? And he said, $25,000 a week tax-free in 1990 dollars. $25,000 a week tax-free wouldn't be bad in 2024 dollars, but in 1990 dollars, that was a lot of money. Even then, more money. And I said, so where's all the money? He said, my family's kind of set up, housing and whatever. And I said, and he said, when I get through my next few years in parole, I'll be able to start being there. And I said, was it worth it? Was it worth it? And he said, he shook his head. He said, I don't know. I wish it wasn't, but it was the only thing I could do. This guy could have been a Warren Buffett. He could have been, a major positive person. He was brilliant. He was well read. He was, clearly a savvy businessman. He knew how to make things happen. He knew how to run organizations, except it was all in the services of the drug universe, as opposed to something that could have been much more productive for a really brilliant guy like this. And it kind of broke my heart, actually.
Why is it? I'm a big movie buff. I'm big on television. I'm confessing, and let me just say, special thank you to Vin McCormick, who owns this network, the New Life Recovery Center. He puts people into treatment. He has a hotel actually down in the 100 block of St. Paul Street, and they provide housing for people seeking recovery, drugs, alcohol, also gambling, and we're going to get to that. But I'm a big television guy, and he's big on getting people into treatment. Just so you know, New Life Recovery.
Great.
And he allows me to broadcast Mondays, Wednesdays, and Fridays at 12 noon. So if you ever want to come,
Thank you, Vin.
Yeah, if you ever want to come on or you want to send someone, just know that's the logo over there. He really does. He has about 24 years clean himself. But anyway, why is it I'm going to say the majority of the movies I watch have alcohol in them? I want to talk about alcohol. It's a drug too, right?
Yep, legal one.
Out of 10 people, how many people struggle with alcohol?
I don't know the answer to that question, but clearly there are. The two legal drugs are alcohol and tobacco. Tobacco has, no possible benefit and all risk. Alcohol, you can argue a little bit, maybe some relaxation, but there clearly is a tendency for a lot of people to become alcoholics. But my clinical experience with alcohol is drunk driving. That's the worst, because I've seen drunk driving. And there were just 3 young men, I think, a few months ago, killed in Prince George's County, athletes, by a drunk driver. There was the road workers, where there was a drunk driver they were speeding 100 miles an hour, killed 6 road workers a couple of years ago. I'm not talking about the bridge. I'm talking about on one of the local highway constructions. And I saw terrible tragedies from drunk driving. And one of the first bills I actually did in the legislature cleaned up a drunk driving loophole. So yeah, alcohol's legal. I don't think we're going to go back to prohibition, but it's clearly an issue that's pretty serious.
But it's like every movie I watch, not every movie, but it's just commonplace. Like right now, I'm watching the SEAL team, the Navy SEALs,
Mm-hmm.
and after every mission, you know, everybody's passing beers and shots of tequila.
I don't think it's a healthy image, but I watch a lot of old movies and they're constantly drinking, and I don't know how they're standing up at that point. But given my own extremely low tolerance for alcohol, but uh, you know, I might have a glass of wine once every 3 months. That's about my level of intake. But I guess they think it sells or it's sexy or whatever. Um, they certainly made smoking look sexy. All you know, the movies, 30s, 40s, 50s, 60s, 70s, 80s, it was cool to be smoking, made the men and women look hot if they smoked. And obviously it was a lot of those actors, died of lung cancer. But anyway, and emphysema. But I have to ask Hollywood that question. I don't do those things. I don't write those scripts.
So, what have you been working on these days?
One issue that I am working on is, and about and getting more involved in, is ER wait times, emergency room wait times. It's everywhere in the nation, ER wait times are too long. And Maryland, ready for this, has the longest ER wait times in the nation. We have the longest ER wait times in the nation. And
Why?
huh?
Why?
That's a really good question, and I will do my best to answer it, but it's not a simple thing. So, the average emergency room, community hospital, of all the patients that come in, 80% are discharged. So, if 100 people come in, 80 go home. Now, 20 get admitted, but the 20 who get admitted tend to make up between 50 and 80% of hospital patients. So, and the community hospital is more like 80, 85%, higher up. Institutions that are more referral, like Johns Hopkins, they're going to have people coming in from other areas. So the ER is the flow through point that determines who gets in the hospital, and you see all the things. So then you have the admitted patient in the ER. You got to get them upstairs. You need to get upstairs for definitive care. There aren't enough, for a host of reasons, enough beds to get them into, or cleaned up beds for people discharged aren't leaving. A lot of it boils down to there isn't enough of the staff that I worked with all the time, the underpaid lower end of the staff that makes everything happen: housekeeping, dietary, clerks, transporters, security, and others, lab techs, all those people. So if somebody leaving, the room doesn't get cleaned right away because there's enough housekeeping. Those people are making $17, $18, $19 an hour. They should be paid a lot more. Number one, we have allegedly a nurse shortage. We don't have a nurse shortage. We have a shortage of nurses who want to work because there's not enough of them and they're overwhelmed. They can't really do nursing. I was touring an emergency room just a couple of nights ago. I like going in at night, like midnight. They said you see the real stuff. Nurses are making $40 an hour, and they're getting a night shift differential. They should be making much more. So, the macro picture, and I'll get to Maryland in a second, the macro picture in this country is that we spend more per capita than any other nation in the world by a lot on healthcare. And while there are amazing advances and incredible technologies, which I'm thrilled as a clinician over my 40 plus 50 years as a doctor to see, we are ranked about overall 60th in overall healthcare statistics. And of course, it's always worse if you're poor or a minority, generally speaking. So where's all the money going? Well, this flow of money comes in, and then there's all these entities that have figured out how to suck some money out. So by the time it gets down to the level where I work, there isn't much there left, and it puts stresses on businesses, small businesses trying to pay health insurance premiums. It puts pressures on people who are employed and have insurance. They're going to say you get a worse program and more copay and self-pay. So where's part of the money going? Well, big chunk of it in hospitals is going to administration. And I don't know if you're aware, Donnie, what hospital administrators in Maryland make. Would you like to take a stab? at what the CEO of MedStar makes. It's all public information, so I'm not sharing anything secret. What do you think he makes?
175 to 200K.
I don't think that may be their weekly rate, but not their annual. He makes $15 million a year. The CEO
What?
of LifeBridge makes $3.5 million a year. All these executives are making seven-figure plus incomes, University of Maryland and so on. And then there's the legions of administrators below them, ones that may be making 3 million. There's ones making 1.5, 200, 1.1 million, and 900,000, 800,000. You can look this up. Go to guidestar.org. You can look up any nonprofit. It's free, name and password. If you don't do more than 50 looks in a period of time, it's free. Then you can enter any nonprofit and see what, and then you go to a thing called a Form 990, which is their tax form. Every nonprofit has to file a Form 990. It's usually a couple of years in arrears for different reasons. And then you can scroll down through those 50 pages, but you'll learn very quickly where it is. They have to post their top 10 employees' salaries, and you'll see it there. And that's what they make. So could the person making 15 million a year survive on 10 million? And by the way, this all drives their pensions too. So when they retire, they get a percentage of what they make. Could they survive on 1 million a year? Well, if they survived on 1 million a year, you'd have 9 million. The guy made 15 million. You'd say, we're going to cut your slash you down to $1 million a year. That's $14 million. For $14 million, you could hire a bunch of nurses and these other people and pay them decent living wage salaries, because they're the people that actually deliver the care. They're the people that make the machinery work. I'll give you a personal anecdote. I had a in and out hernia operation a few years ago. Everything was fine, except when it came time to leave. I'm waiting for the person to come with the wheelchair to wheel me out. They don't like you to walk out. I could have walked out. I was a doctor at the hospital. I didn't want it. It was different, not where I work, but someplace I knew. So my wife's out in the car for about 50 minutes waiting for me. Finally, the guy comes and he says, okay, get in the wheelchair. I'll wheel you 100 feet. That I could have walked, but I wasn't going to break the rules. So I said to him, where you been? He said, well, I got to discharge 20 people in 2 hours. But, you at least can move, get in the chair and get out. But there are other people, I got to help them into the chair. Then I get them outside. I have to help them into the car. It's not easy. They forgot something in the room. I go back and get it. Why aren't there 3 of this person? This guy's making, low end salary. Pay them more. They deserve more. I've worked with clerks in the emergency room. I could never do that job. They're like air traffic controllers in chaos. Phones are ringing. Where's Dr. So-and-so? What about this? Family's calling. Is this the right family? Name sounds like a lot of Glovers. Is it Donnie Glover or Derek Glover? I don't know. Let's start that, and they deserve a lot more money. The nurses deserve more. The physician's assistants deserve more money. All the techs, the aides deserve a lot more money, because they're the ones actually doing the work, but they're not rewarded. What's rewarded is the big executive suites. Most of the big systems now have executive suites not even connected to the hospital. So they never even set foot in the damn place anymore. At least when I started as a doctor, some of the administrators actually, would come around and visit the ER. There's no reason to do that now. You're located elsewhere. So, the money is there. I wrote an op-ed with a colleague in the Baltimore Sun called ER Wait Times. Part of the fix is, and the way the Sun did the headline was, cut administrative salaries a lot. We proposed that administrative salaries be capped at $500,000 a year, which would have freed up $100 million. And $500,000 is a, adequate living wage in this state. So I'm being pretty direct. I've been public about this. It doesn't make me popular in some circles. Can I say that's okay? But I work with a lot of folks who deserve a lot more money for the actual work that they're doing. And since we have the longest ER wait times in the nation, I don't believe the administrators deserve the salaries they're getting, because they aren't getting the job done. And there are other reasons. We need to have more primary care and preventive care. People need to take more personal responsibility for their own behavior. I mean, no one's putting a cigarette in your mouth. No one's putting that pastry instead of a carrot in your mouth. Got all these other factors going on. We don't have enough senior places for people who are discharged from a hospital, go to a nursing home, and that's a whole separate kind of thing. So they're getting the support at home. I mean, there's a lot of ripples and a lot of issues, but there's a lot of money in healthcare. It's just not actually going to the servicing of patients and providers who actually do the work.
Is are food deserts something that come across your desk?
I know about them. I certainly think that diet's a big factor. I will say personally, there was a point in my life where I was in pretty good shape and I got kind of casual and I got to be pretty fat. There's no other way. Can't sugarcoat it. I got to be pretty porky guy. And a couple of health issues woke me up and I changed my life and my diet and got in shape.
I mean, like here in West Baltimore.
But food deserts are important, but people can still make choices within that limited framework. But I became a vegetarian. That helped me a lot. So that's me.
You're a veggie?
Yeah, last 8 years, I don't eat any animals. Not fish, not chicken, not, I think we've kind of treated the animals of the planet badly, for one. I think they're creatures we ought to respect. And then, we raise them and slaughter them en masse. We overfish the oceans. The chickens are kept in coops. Pigs are, which are actually pretty intelligent animals, are kept, in a cage that they can't even turn around. I mean, it's a horror show. And then the foods are often pumped full of chemicals of various kinds. And I think it's just better not to eat them. And I feel a whole lot better. It took a while to change my diet, but celery and carrots are pretty cheap too. So you can usually find stuff like that. But
what was the content of your last meal?
What I do is, it's a good question. I just take whatever veggies are in season, chop them up into a big salad, and throw in, things like tofu or seeds and nuts or something like that to get the protein. I do eat hard-boiled eggs, but I get them from a local farm where I know the chickens are well treated, and I do eat some dairy, which is again, I try to be a little more conscious about. Getting organic dairy products, but that's pretty limited. Both are pretty limited for me. You can live very well, and it's way less expensive to buy veggies for the most part.
What's tofu made of?
Soybeans. Mm-hmm. And there's this thing called tempeh. You can get at Trader Joe's for $2.99. It's very easy to put into any food, and it's organic. It's pretty good.
You use salad dressing?
No, they just use vinegar. No oil. It's a taste bud adjustment. I have to say, for the beginning, first year, it was hard. And there were a few times in the last few years, where I will be served something at somebody's house and it's a meat thing, and I'll eat a little bit of it. But I really worked to avoid it, and probably haven't had a bite of animal in months and months.
Is your wife a veggie too?
No, but we get along. But she's pretty limited in her animal eating. Yeah, she's pretty limited.
Any advice on relationships?
What kind?
Man, woman.
I wish I could. Shelley and I, this June 1st, 2025, will have been married 50 years.
Praise God.
That's pretty good. She says 38 wonderful years, 38 out of 50 is not bad. So I don't know about relationships. I struggle with them all the time. I don't do as well as other people, even in the legislature. The legislature, I was not one of the popular people. I was too, pretty driven, pretty focused, intense.
Man, people aren't staying together 50 days.
I'm lucky. I'm blessed. She's a wonderful, brilliant woman, and I don't know why she stays with me, but she does, and I love her. But I'm more intense than most people.
Well, you're a brilliant man now. I'm not going to downplay that, and you're a great friend.
Thank you. I don't do as well as others in that aspect of things.
How do you know?
Well, I can just see, but I stick, to the lane that I'm comfortable in, and I don't need look at this point. I don't even need to take on some of these topics. When you write an op-ed in the Baltimore Sun that says, that tax every administrator in the hospital administrator in the state, that's like taking a baseball bat to a hornet's nest. You know, some of the other positions I've taken over the years about drug decriminalization or overdose prevention sites or getting insurance companies to take more responsibility or other things. Even some of the MBE stuff where you and I met. Um, you know, I took some beatings along the way, but you stick to what you think is right and hope it works out. And other people have done far more impressive things and intense things than me. Um, sometimes people said, "Oh, you're so brave to do that." Nah, it's just political risk. You're not walking across the bridge into a um, fighting segregation where there's police on the other side ready to beat the crap out of you. I don't face those kinds of things. So
T- tell me what a politician goes through, what an elected official goes through in terms of mental health.
that's a really good question. I found a lot of my time in office was not good for my mental health, partly because your ego kind of soars even at the lowly level of Maryland House of Delegates for 24 years. You begin to think that you're really important and people treat you differently. Before I was elected, go into some gathering of people and kind of stand there by myself. Nobody's really talking to you. Maybe I go up to a few people, try to introduce myself. There's sort of it's awkward moment. Then I got elected. I walk into the room and everybody comes over and talks to you. They want to have a piece of your time, and it's fine. I get it, but it tends to inflate your ego in a way that's not healthy. And that's probably the hardest thing in terms of what I experienced. And I also saw some people who got a little too carried away with alcohol on occasion. Um, Others, little inappropriate events taking place. So, um, I could understand how it happened. That doesn't mean it's a good thing, but I could understand how it happened. But after 24 years in office, that was enough for me. I think political life should have a beginning, a middle, and an end. And it's not be your total wrapped up as your total identity. And too many political people, that becomes everything they're all about. And that's not a good place to be.
Is it easy for elected officials to forget why they got into politics in the first place?
I think for some it is. I mean, everybody I think retains a kernel. I think most people went into it for the right reasons. They wanted to make a difference and do something good, but it gets, beaten, worn out for many along the way. And there's a real tendency to go along, get along approach. But generally, I respected my colleagues even when they disagreed with me on stuff. And there were a couple of people I became very good friends with, even though we disagreed on key issues, because we found ways to work together on other things. So we never want to categorize somebody as all this or all that. There's nuance in everybody, and if you can find those areas where you can connect, then it works. You and I
What was
come
the
from different backgrounds, and yet we're connected. Doesn't mean we agree on everything, but here we are,
well,
years of friendship later.
tell me about the good
The good of,
being an elected official.
oh, you get to do a lot of stuff, make a difference. I like to think that, I was just looking over some of the bills that I'd passed a couple of days ago, and I saw a lot that made a huge difference. Many don't even know that I did them or what happened. So, I can give you a couple of examples. The very first bill I got passed actually was an agriculture bill. It promoted, you ready for this? This is 1998, I think, organic food, the wine industry, and farmers markets. So organic food, self-explanatory. The wine industry in Maryland at the time, we had 3 wineries. Pennsylvania had a lot. Virginia had a lot. Why didn't we? So this was a mechanism. I won't go into the details. Promote the wine industry. And farmers markets were little roadside stands that a farmer would occasionally do. Now we have farmers markets, downtown, Waverly, elsewhere, around Baltimore County. These big farm. That bill generated all of that. Nobody knows that I did that. But every time I go to a farmer's market or see a new winery, I think, yeah, I had a little help with that. I did a bill on colon cancer screening. It's kind of overlooked, and that's people still occasionally come up to say thank you that I got screened because they found colon cancer early, which is, by the way, now in younger populations. but it was very hard to get initially. I knew medically that that was something. I had a bill that helped children with cleft lip and palate, sort of been an ignored issue. And insurance companies would only pay for one surgery, but it takes, I learned, and I knew it would take several surgeries as the kids grew and their face changed to have it repaired. So I got a bill to fix that. There were also things in the legislature that I went into knowing nothing about, and people taught me. One of the best things about being a delegate, I would say, is I met people from all over the state and learned about a lot of things that I did not know about. And whatever I was passionate about, other people were equally as passionate about on some other issue. And they would look at me and say, this guy doesn't know anything about our most important issue. It might be an issue about fishing in the bay or forestry or some other kinds of problems, and they would school me on that stuff. They would learn, I'd sit down and say, explain to me how this works. Maybe something about real estate. I mean, I own a house. That's the extent of my real estate knowledge. But if you're going to change the real estate transfer tax from 0.012 to 0.019, what does that mean? I don't know. So I'd learn, does this help buyers? Does this help sellers? Does this address housing? Does extra money in the tax go for things that are worthwhile and maybe deal with some of our housing issues? So I had to learn a lot, and that was the thing I actually enjoyed most about the job. Meaning, I have friends, in the legislature from Allegheny County. This is not something that probably just would have happened if I had not been in the legislature. And you, one of my all-time favorites. So.
But you were the only physician in the Maryland General Assembly for many years until Clarence Lamb came along.
Either one. Well, Andy Harris was there for some of my overlap. Andy and I had pretty much polar political opposites with a few exceptions. The Venn diagram of our overlap is kind of some hardcore physician issues. But other than that, we differ on most things. But Clarence Lamb's great. Terry Hill is great. We have two excellent physicians in the legislature now. And after they got elected, that was another thing that helped me decide not to run. The torch is being carried on.
Any final thoughts?
Thank you for all that you do. Thank you for having me on the show. The final thought is this: if you're listening, all these things we talk about are things that others can do. The one thing only you can do is complete your advance directive. Not your congressman, not your pastor, not your rabbi, not your imam, not your mom, not your sister, not your brother, only you. And so please complete your advance directive. Go online, mydirectives.com. Go to the Attorney General's website. If you have a deep faith affiliation, they've got them too. Go to AARP, but complete the paperwork. Make sure it's available, not hidden in a drawer, filing cabinet, safety deposit box. You circulated it. Get it to your clinicians, your doctors, and who take care of you. It's the one. It's free, no cost, and will empower you in a whole lot of ways that probably aren't happening now, but will likely happen in the future, and you want to be prepared for it. That's my one request.
Because no one gets out alive.
No one gets out alive. But the end comes, and it can be more managed, better managed, more holistically, comfortably to your own set of values and preferences, and it's ultimately better for your family. And it changes the whole dynamic of this universal experience.
Dr. Dan Morhaim, author of The Bitter End.
Better End.
The Better End.
Better End. Amazon,
End.
Kindle. There's an audio version now, Audible. So libraries, all available. Go read the book. Endorsed by Maya Angelou. Someday we'll have to talk about Maya Angelou, my friend.
Yes,
I've got to be friends with her.
Yes, sir. The one and only Dr. Dan Morhaim. I love you.
I love you too. Thanks.
Yes, sir. You've been watching the New Life Recovery Show, brought to you by New Life Recovery Center. We'll catch you on Monday at 12 noon. Good afternoon. Thanks, Doc.